Hello, my name is Emily Moon, and today, February 21st, I will be presenting my case presentation on asthma. Typical patient presentation. A 12-year-old female presents to her physician with episodes of dyspnea, coughing, and chest pain. She reports having an increased frequency of persistent coughing at night and during exercise. She exhibits a distinct wheezing noise when exhaling and has a history of seasonal allergic rhinitis. Asthma is a chronic condition which occurs when the inner walls of one's airways constrict. Asthma is also caused by bronchial hyperresponsiveness, which is an increase of airway sensitivity to an inhaled constrictor agonist, and hypersecretion of mucus, which obstructs the respiratory airways, making oxygen exchange difficult. Another key aspect of asthma's etiology is the narrowing of air passages in one's lungs, followed by the swelling of bronchial membranes. These are the known causes for asthma. Asthma affects roughly 235 million individuals around the world, with a mortality rate of 4,000 each year. It is also important to note that asthma is the most prevalent or common chronic disease for children under the age of 18. From an economic perspective, asthma-related circumstances such as healthcare costs, mortality, and missed school or work days accounted for $81.9 billion annually in the United States. The image provided displays a few brief statistics regarding asthma and its effects in the U.S. Asthma is a familiar disorder with more than 100 identified genes that play a role in the disease's susceptibility. Therefore, family history of asthma is an indicator of higher risk because one's genetic makeup predisposes the inheritability of asthma. Atopy is a genetic tendency to develop allergic diseases such as allergic rhinitis and atopic dermatitis. The proposed process is that the allergen exposure produces allergic sensitization and that continual exposure leads to clinical asthma through repeated airflow obstruction. Atopy is closely related to the risk factor of enhanced immunoglobulin E response, as its production occurs in reaction to environmental substances or common allergens. The constant overstimulation of one's immune system enhances respiratory sensitivity and increases the risk of developing asthma. Exposure to inhaled irritants can cause inflammation and damage to airways, independent of allergen sensitivity. This leads to irritant asthma as well as increased hyperresponsiveness of the airways to allergens in those with a history of atopy. Inhaled irritants include air pollution, tobacco smoke exposure, chemical fumes, and industrial or wood dust. Severe and recurrent respiratory infections during childhood are associated with onset asthma, as the symptoms of early wheezing leads to complications in one's respiratory system. These viruses, such as respiratory, syncytial virus, and rhinovirus, are examples of respiratory viral infections. Gastroesophageal reflux disease, sinusitis, and obstructive sleep apnea are also associated with an increased risk of clinical asthma exacerbations. These diseases contribute to dyspnea through the swelling and constriction of airways. For example, in gastroesophageal reflux disease, gastric acid irritates the nerve endings in the esophagus, which creates impulses to the lungs, stimulating the muscle and mucus production in the airways. Another important risk factor for asthma are beta-adrenergic blocking agents that bind to beta-adrenoceptors and block the effects of epinephrine and norepinephrine. Functionally, epinephrine increases the force and rate of myocardial contraction and relaxes bronchial smooth muscles. Its blockage creates the opposite response. For that reason, beta blockers are regarded as contraindicated in patients with asthma due to the potential risk of triggering bronchospasm and airway reactivity. Similarly, aspirin and other non-steroidal anti-inflammatory drugs can induce bronchial constriction in some asthmatic patients. The pathophysiology of asthma involves airway inflammation when an inflammatory cell responds to immunoglobulin E. IgE antibodies respond to triggers in the environment and bind to high-affinity mast cells and basophils. When a pollutant gets inhaled, the mast cells release cytokines, histamines, and leukotrienes, which causes intermediate airflow obstruction due to airway edema and mucus secretion. Pathological changes include bronchospasm or bronchial hyperresponsiveness, which is an increase of sensitivity to a variety of airway-narrowing stimuli. Additionally, structural changes of airways occur, such as smooth muscle hyplasia, which is an increase of smooth muscle cell size, hypertrophy of bronchial glands, fibrosis of the subepithelial basement membrane, and the thickening of airway epithelium. Triggers that cause airway inflammation include exposure to allergens, environmental irritants, viruses, cold air, or exercise. This is an in-depth analysis of the physiological processes associated with asthma. First, as previously discussed, asthma exacerbations from environmental factors cause immune cells to generate inflammation. Antigen exposure to the bronchial mucosa activates dendritic cells, which prevents antigens to helper T cells. Those differentiate into Th2 cells, releasing inflammatory cytokines and interleukins that activate B lymphocytes and eosinophils. The cross-linking of IgE molecules with the antigen causes mast cell degranulation with the release of inflammatory mediators. Interleukin-4 and interleukin-5 are cytokines that release histamines, leukotrienes, prostaglandins, and more cytokines. These contribute to smooth muscle contraction and increased mucus secretion, obstructing airflow and creating asthmatic symptoms. This image is an overview of the pathology of asthma, starting with genetic factors and environmental factors, triggers discussed in the previous slide with examples, and the body's response to exposure of triggers. Here you can differentiate between early response and delayed response. What's important about this slide is how vascular permeability leads to edema of airway mucosa, and goblet cell hyplasia increases mucus secretion. These outcomes, along with bronchial smooth contractions, increases airway obstruction. This image can help visualize pathogenic processes of asthma as well as its effects. An overview of the end result and a visual aid of the airway is seen in this slide. This is a normal airway, and as you can see, the asthmatic airway has been inflamed and thickened in comparison. During an asthma attack, the walls become even more narrow, with more mucus secretion and tightened smooth muscles, trapping the air in the alveoli. Over time, the effects lead to edema, scarring, fibrosis, and permanent thickening of the basement membrane. Symptoms of asthma include dyspnea, which is difficult or labored breathing, and chest constriction due to inflamed or swollen airways. This can physically manifest as chest tightness, pressure, or pain. Externally, asthma presents as expiratory wheezing due to narrowed airway passages. Non-productive coughing is a response to the irritant that forces the bronchial tubes to constrict. It may also be associated with hypersecretion of mucus that builds up in the lungs. Symptom-free periods and asthma exacerbations, which are acute and sudden asthma attacks, are typical as the severity of one's condition changes periodically. Medical professionals diagnose asthma by analyzing the frequency and quality of symptoms presented. Usually, symptoms appear worse at night, vary in length and intensity, and are worse with common triggers. The presence of wheezing is a strong indicator for asthma, although patients can conduct normal physical examinations between asthma attacks. Wheezing is presented more often during expiration. Lab tests include a peak meter flow, which examines how well a patient's lung can expel air. This test measures the force of air in liters per minute. In asthma patients, a decreased peak expiratory rate is less than 50% and is an indicator of airway obstruction. To test pulmonary function, a spirometry is used to measure how much air is inhaled and exhaled by a patient, as well as their ability to efficiently perform the task. Medical professionals also examine a patient's medical history, as some aforementioned diseases and conditions are indicators of developing asthma. Others include rhinitis, nasal prolapse, swollen nasal turbinate, enlarged lymph node, laryngeal web, or eczema. The treatment of asthma can be separated into two categories. Quick relief medications provide instant alleviation of asthma symptoms. These include short-acting beta agonists, anticlogenic agents, and oral corticosteroids. Treatments for acute asthma flare-ups reduce inflammation and swelling by relaxing the airways, reducing mucus production, and protecting against bronchospasm. Long-term medications involve daily corticosteroids, combination inhalers, biologics, and leukotriene modifiers. Using these treatments regularly can help a patient maintain control over persistent asthma attacks and decrease their frequency. Treatments for asthma are often prescribed in the form of inhalers, which are delivered immediately to the lungs to inhibit the inflammatory process that occurs in asthma. It is also important to note that those with asthma are advised to avoid allergens and irritants that may trigger or worsen their condition. These are my references, and this concludes my case presentation. Thank you.